let me follow up on that and drill down just a little bit, right? So you talked about a need for systemic change, basically, right, in terms of uptake. So there are a couple of things that opens up. And rather than be very prescriptive with the question, I'm going to throw a couple of topics out there that I'd kind of like to understand from both the provider and payer perspective on the systemic change. We've been talking about it from a cardiology point of view. What's the role of endocrine in primary care? Are those docs going to be blocked from usage of these drugs? Will they be prescriber dependent in terms of the specialty and level of training? And what are you doing in terms of the different perspectives, what are you doing to educate other clinicians about changing the standard of care here?
Well, you make a very good point, which is that, and please correct me if I'm wrong, Jaime may have better data than any of us have, but most patients with diabetes in America are not taken care of by either an endocrinologist or a cardiologist. They're being cared for by an internist or a family practitioner. And we maybe need to do a better job of speaking to those audiences. Now, they have professional societies, they have meetings, they have other things, but you know, we got to be careful. We're not just talking to each other. We got to talk to the people that are actually on the front lines here that are managing these patients. And that's where clinical inertia is pretty strong. And I'd be interested in Jaime's comments about this. Am I right that mostly diabetes is being treated by primary care physicians?
Yes, you're absolutely right about that. And you touched on something that is close to my heart, which is a lot of the work that we do, let's say as a cardiologist, I think all of us will recognize that if properly done, can be perfectly done by a team care, you know, the team approach to care. In a fee-for-service environment, you have the cardiologist and the endocrinologist seeing every patient in the office because that's the only thing that pays. What if we enroll or engage, like many ACOs do, for instance, the cardiologist working closely and the endocrinologist with the primary care community and said, just call me, I'll give you directions, I'll educate you. At the end of the day, we're all in together. And what really matters is that we keep this person out of the hospital. They have a better quality of life, that we prevent them from developing kidney disease. So that's the real, I think that's the winning formula, is that we need to avoid that segregation, that compartmentalization of care that we have today, because it's essentially, unfortunately, incentivized by a fee-for-service system. So the moment we said everybody wins in this, that's where we're going to see that collaboration.
Clarification question, is that for patients with diabetes and heart failure or just all heart failure patients?
No, I think Dr. Neeson was asking about diabetic patients in general, being taken care mostly by primary care physicians.
Yeah, right. But even I would say that the same thing is true for people with heart failure. I mean, most heart failure patients are not seeing, we got a group of heart failure doctors at the Cleveland Clinic. They're very good, but mostly it's primary care that's taking care of it. So it's true for both of these. Now, collaboration is a wonderful, idealistic goal, but let me say that it's pretty challenging. The average primary care physician, I don't know how many patients they see a day, but it's a lot. And we're all under that kind of time pressure as well. And, this kind of cross-disciplinary care takes time. It's not necessarily paid for, so, we all try when we can to get on the phone to our colleagues and say, I saw your patient with X, Y, or Z, and I'm making these recommendations, but it is hard to manage that collaboration. And I wanted to make one additional point. And that is, you said, Nihar, that we can use the EHR, and I agree with you completely. For some diseases, we now have pop-ups. When a patient has a constellation of signs and symptoms, something pops up on the screen that says, have you considered X, Y, or Z? Or why is this patient not on an ACE inhibitor? I think we've got to leverage the power of the EHR much more effectively to manage this problem of the underutilization of effective therapies.
I think that is a key point, that we have, I think, systematically underinvested in doing real implementation science. You know, like what are the elements that really drive, you know, adoption of high value therapies? How do you engage with providers? How do you use the EHR? What do patients want? What kind of shared decision making do we have to put in place to really get to that kind of system that we all want? And then, you know, I think relatedly, from kind of a system level point, Neil, I think, you know, I think there has to be some reformation, if you will, in our quality measurement, right? If your quality measures are still around blood glucose and A1C, and you know, that sort of reinforces this mindset of, hey, all you need to do is lower the A1C, and you can use, you know, one of these, you know, 7 different things that are available to you, versus, you know, how do you improve outcomes, you know, for the patient, and that quality metrics really have to incentivize things that are very well aligned with clinical outcomes. And I think relatedly, the payment system has to do that too, right? I think we've all touched on this, but if you sort of got to a new system where you were incentivized to, you know, take care of a population of patients, and if the patient did better, then everyone did better. And I think that would sort of really enable the use of high value therapies, even if the drugs cost a little bit more. But if the total cost of managing that patient was dramatically reduced, then I think you would, again, sort of create a milieu where, you know, the patient wins, potentially the pharmaceutical manufacturers that are developing high value therapies win, and the health systems and the providers, you know, win, and the payers win. And I think that's what we're going for. And I think that's the real potential of the SGLT2 inhibitors. If you can really sort of get to that win-win-win kind of scenario, because they're so effective.
And would that be what drives earlier adoption in heart failure independent of diabetes?
Yeah, Neil, absolutely. I mean, I think for us, if you think about our ACO patients, the patients that are in the bundled payment program, and you have an intervention that reduces the risk of rehospitalization by 25 or 30%, that's an incredibly high value intervention for those patients, right? The patients love it because they get to be at home and carry on with their lives. The providers are delivering best evidence-based therapy, and the health system is winning because, hey, what a novel idea. You know, like when the patient does better and they have better outcomes, you're actually financially rewarded for that too.
So any other comments before we start to move on?
Just one more last comment to Nir's point. The cost of one heart failure hospitalization can pay for an awful lot of drugs for an awful long time. And, you know, I mean, add it up. And I don't know, you know, maybe Jaime can tell us what is the average cost for a heart failure hospitalization now in America? It's a lot of money.
Yeah, it is a lot of money. I mean, obviously depends on where you are, what part of the country, and so on. But I will just throw a number there: $22,000. It's not unreasonable.
Yeah, the Medicare range is between 20 and 25.
Yeah.
That's just an incredible amount of money. And you know, if you look at the cost of, you know, drugs like SGLT2 inhibitors, I mean, you really have a value proposition here that's worth thinking about.